So I'm going to talk about a couple of cases that I've done that are a little bit different than the standard IlluminOss. I've done that webinar on this platform actually before with everybody, so I'm happy to talk about the standard tripod and humerus at any point, but these ones were a little bit different to try and give a little bit of a different perspective. So the first one is a pathologic fracture of a humerus through a multiple myeloma lesion. It was supracondylar. This was a patient, I believe we also were nailing his femur when he broke his arm, and then he had to have some kyphoplasties and things too. It was a pretty severe case at presentation. So we really thought he needed to get his arm to a weight-bearing point to be able to rehab his other injuries. And so in this case, I decided that a antegrade nail of any kind would not really have enough room in the canal distally. And so we decided to actually consider this more like a pediatric supracondylar fracture and use the IlluminOss in a retrograde fashion. My original plan was to go with a lateral column and then actually come over and do a medial cross pin, since obviously I don't have two pins like I would in a kid, nor would they bypass the fracture. But turns out it's a little bit harder to make that turn in an adult who doesn't have an all cartilage elbow, especially with as prominent of a medial epicondyle as this patient had. So after struggling for some time, this is the lateral, and I'm sorry about the x-ray on the left. I could not get that to look any clearer from the fluoro shots that were saved. But those were our starting pin x-rays. And then I don't know why they didn't share them, maybe because none of them turned out very well, but we didn't save any fluoro on the medial epicondyle. And it was one of those moments where I was like, do we open up and plate this? What do we do next? And so, this is the beauty of this system, is I knew I needed at least two balloons, I felt, if I was going to get away with no plate, to stabilize this without having to splint him and get him mobilizing afterwards. And so I actually just went from the top. So I just went to the metaphysis and put down a guide wire through an all hole. I did remove this balloon. We had never inflated. I did remove that before reaming, as you can see on the x-ray on the far right, just so we didn't mess up the balloon covering. And yeah, then once I had both of the balloons positioned, I sequentially inflated them back and forth until I felt like our reduction was adequate. And it actually turned out very, very well. On the left are his immediate post-op x-rays. You can see on the right, as he healed, we did end up with a little bit of flexion through the fracture site. But on the AP, the varus valgus was actually very, very good, and he was very, very happy. So again, kind of a case example just to show how versatile this is. I have a partner who a couple of days ago tried to do something similar in a patient who had a myeloma lesion, same location, but much bigger up the diaphysis, and then had a medial condylar lesion as well that he was trying to stabilize. So he used the same sort of retrograde idea from the medial epicondyle. He was able to get it where, as I showed in this case, I was not, and then plated it as well, which I think is another option. But this we were very, very happy with. And I don't think this patient is still with us. I think he passed, but in terms of his bone issues, we were very happy with his fixation. And again, this was, even though the case took a long time, the patient was weight bearing as tolerated immediately, and we got him in range of motion pretty quickly. And
can I ask about
yeah, please.
So was your plan, you said when you say cross-pin, do you mean a second photodynamic nail or interlocking?
Second photodynamic nail. I was going to go medial, and I was going to do the lateral epicondyle and a medial epicondyle, put two balloons up because I didn't think one from one column was going to be enough to stabilize the fracture.
Got it. Did you clinically during the surgery, after the balloons were inflated or cured, did you test the rotation of the arm to see if you wanted to interlock the device?
Yeah, so rotationally, he was stable. You can see there's a little flexion there. I can't recall if we noticed a little bit of motion through the segment in terms of flexion extension varus valgus at the time of surgery. But I did feel like it was stable enough that he would be able to weight bear through it. And rotationally, I didn't have any issues. It was more just the flexion extension. I found that with the proximal humerus as well. I used to put interlocks above and below the fracture. And then one day I started fluoroing them after I inflated the balloon, and I found them, for the most part, with very few exceptions, to be rotationally stable.
Brooke, what size balloons do you like to use for this?
I
Like,
think
do you
in
have a
this case,
preference?
I think in this case, these were nines. But yeah, I think that I did use nines for these. I knew they were going to be short, or excuse me, narrow, just because of the distal humerus canal. I haven't used anything smaller distally. I theoretically, and my partner who did this case recently with the plate on the medial epicondyle, he had discussed, I don't think he ended up doing this, but he had discussed even using a bigger balloon, like a 1311 or something, just to get all the way up, because he had such a bigger diaphyseal involvement of the lesion. And so I think you can always use the bigger one if you really feel like you need more length. But in this case, because I was doing two balloons, I just used nines.
Well, I think this is a great case showing the versatility of like starting from different areas. Like, you don't have to use your traditional starting points. And this for like lesions that are distal is very useful. Even if you're going to play them, I tend to play them. Like, I usually don't do it if the patient is like too sick or has like very extensive involvement, like look like your patient was like you're doing the femur,
Right.
you have this lesion, and like to have more incisions that are going to need time to heal. And you always can go back later if you need to. And
Right.
like, you don't have to do everything on the same setting. Sometimes these ones can fracture because you have the presence of the fracture, and like a common question is like, oh, now what do I do? And the main thing is like, you don't have to remove the balloon because it broke. You actually can leave it in place, and having the piece inside the fragment helps you to have better control of the bone. And when you're putting the plate, you actually can sink the plate better and get it better compression, and make the fracture treat the fracture without the bone crumbling in front of you. Well, let's see your second case. That was great.
Thanks. And this one kind of highlights some of the points you were making, Dr. Lozano. So this is a non-tripod pelvis that I did. And you'll notice that both of these fractures, and I think this is a critical point. I mentioned a renal cell carcinoma, but this is myeloma and breast. So there was some element of me hoping and praying for some healing around these fractures because of the tumor type. And I think had these been renal cells or lung or something where I'm a little less certain of healing, or certain that they won't heal, some of my fixation would have been different. But on these two tumor types, I do tend to rely on biology a little bit more than I would in others. So this is a patient. You can see with the CT scan that I have her pelvis there. If you were able to see the entire axial cut, you would understand the level of soft tissue around her as well. So this is a morbidly obese, more of a Southern girl than the CT is really showing. Yeah, so she had this path fracture through a breast met. You can see it's partially treated. There's some sclerosis there. She had some radiation, so we're not sure if it was really live tumor there anymore that was causing the problem, or if it was a radiation-induced fracture. And so what I did for this, I think the coronal shows it a little bit better, but I essentially put two different IlluminOss down this from the crest, almost like lag screws. One almost into the anterior column, although I didn't think I needed to be all the way down there. And then one a little bit more posterior, slightly divergent. And I think, yeah, I have some good fluoro shots of it. And so she did well, and we actually got a pretty nice reduction on her. If you look over on the right side, the fracture kind of lined up really nicely. This was her post-op x-ray, and she did very, very, very well in terms of her pain. She was somebody, again, big torso, big lady. Anytime she was moving, she was having a ton of pain, which if any of you have dealt with ilium fractures, you're very familiar with this. They're kind of miserable for the patient until they heal. And then over the course of about 9 months, um, this was my post-op CT, which I get on all of my IlluminOss pelvises, just as part of my protocol, just to make sure there's no major issues with the balloons. So this shows that the lagging kind of worked pretty well. We got both balloons across the fracture. And then that's the coronal view again. And then about 9 months later, again, a big lady, maybe 300 pounds, big BMI, and at least in the 40s, if not the 50s, she displaced. But what was interesting about it is she didn't have any, and this is what Dr. Lozano was speaking about with the balloons breaking. Her pain was much different. So she didn't have pain at the fracture site or where we had operated. Her pain was now SI joint pain, but it still was weight bearing. And so we did end up, I think this was a PET. So we did end up getting a PET scan, and you can see, even though the fracture that we treated is still there, there's some callus around it. The balloons had clearly bent, if not broken, but it's actually more this SI joint fracture, this ilium fracture way back in the back of the pelvis, which on some of the CT scans, I think may have propagated from her original fracture, but I couldn't. Some of these were PET scan CTs, so I didn't have all of the recons that I would have liked to say that for sure. And so I talked to her about going back and fixing, because at this point her pain was a lot worse than what it had been in her anterior pelvis. And I chose to put in a LC2 column, IlluminOss, and you can kind of get the idea as to why I chose to do that on this image, to kind of again lag that fracture in the back. But I didn't think that was quite enough for her, looking at all the CT scan images of the fracture. And so I did add a plate, but I didn't add the plate to the anterior ilium fracture because she had no symptoms there. I added the plate on top of the LC2 screw. So this was my IlluminOss after I had placed it, the LC2, and I did go anterior to posterior for this, just because I was going to be in the inner table for the plate. And then I plated her here. And again, this was under, I would say, direct visualization, but she was a heavy lady, so a lot of my visualization was with my fingertips. But I was able to get a reasonably good reduction and plate fixation, and she is weight bearing, is tolerated again now. And I'm hopeful that she will not continue to progress with this fracture, because her disease is actually stable. And as far as she's aware, she's in some level of remission for her breast cancer. This is all in some ways a win, because her cancer has been treated, and now we're just trying to keep her comfortable and functional.
Very nice. So I think this highlights, sometimes I think we, in this camp of the pelvic surgery, people think that we're in camps, and it's like, oh, I'm a balloon guy, or I'm a plate guy, or I'm a screw guy. And like the reality is, like, you have to be all guy or girl, right? Like you just have to, there are different tools, and you can combine them. And there is not one surgery that fix, or one technique that fix all. It's just your thought process of how you assign different technologies and different things to treat your patient in the best manner. So this is a great case of a combine different approaches to get the goal that you want in very difficult bone, radiated bone, which I think is a game changer when you're trying to deal with this. I totally agree with you with the iliac fractures. Like, I think we're too quick and being like, oh, it's nothing to do. Like, you're fine. Just take some more pain medication and you'll be fine. And patients are miserable with that. And I think these minimal invasive techniques, using balloons or screws, like, allow you to make little incisions and get those bones to stop moving. And they're like game changer from the patient's perspective in terms of pain control. You said that you put this supracitabular balloon anterior to posterior.
Yeah.
Do you have any tricks for that? Same question for Ian. And is it too different to compare to what you do when you do the screw, like I think most of us, or most people do things supine. I rebelled and I like switch and I went to posterior all in. I tried to do a K supine here and there just so I don't forget how to do it. So what tricks do you have when you're doing it supine, and how you control like the falling of the drill, like if you do something with the
Yeah.
tendon, for the
I think it
exposure?
depends for me on what I'm really trying to accomplish. So for this patient, I knew I was going to open up the retroperitoneal space, and I was going to elevate the iliacus off, and I was going to plate her. So for she was going to be supine, otherwise I was going to have to reposition her.
Okay.
In terms of patients where I think they, like I'm putting in a tripod and I think I'm going to do a total hip at the same time, I'll put them lateral. If it's
Okay.
just a tripod and there's enough bone, and again, you're the one that taught me that. I will put them prone. I think that's actually a very easy, probably one of the easiest positioning in terms of ergonomics for the surgeon. And having said that, there was a case that I tried to do an antegrade anterior column and called Dr. Lozano after several hours of struggling because there was a huge acetabular defect. And he was like, just put her supine and put it through the pubis. And so I think having that versatility of being able to do it in every position helps. In this case, like I said, the reason that we went, the fracture was much more posterior. So I just buried the balloon because I knew I had to put the plate on. Had she not needed the plate, I probably would have proned her.
Prone.
And like I said, I usually only do a lateral if I'm doing something else with their pelvis or their hip that requires me to do an incision there and get into the acetabulum. But I have a fellow that I trained who only does them supine. I have a junior partner now who only likes to do them prone, I think. So I have people who get very set in their ways. But I have found that being able to do them in each position is actually pretty important just because sometimes I need to do something different besides just placing the balloons.
Ian, your tricks. What do you have there?
I am all in on prone now for impending fractures, and for displaced fractures tend to go supine. And
Okay.
what I would say is that typically when I need to do staged work for column fixation and total hip arthroplasty, I stage it. And so I don't find myself in
Okay.
a lateral position fixing the pelvis and then doing a hip. On a few occasions have done it in the same setting but changed positions. And so I think that just starting, one of the things that really helped me was the having the sawbones model in the OR and putting in the position I'm in. So either prone or supine, and being able to look and thinking about your hands and the angle of your hands matching the ilium, as silly as it sounds.
Yeah.
And then thinking about how the gantry of your C-arm will be orthogonal to the ilium when you need it to be. And then the planning, I think, really has helped with understanding where the fluoroscope needs to be. I don't do much navigation for these. It's mostly fluoroscopy. And
Mhm.
so taking apart the CT scan, and I can show a video maybe, but it's not part of what I had planned, is changing the angle of the gantry on the CT scan so that you're parallel to the ilium in terms of how externally rotated and less rotated someone's ilium is compared to their sacrum, has really helped with understanding the ergonomics and contours of where you have to go. Um, in terms of that transverse acetabular or LC2 screw, if you will, and then on the posterior column especially. So I think that drawing it out, on paper, looking at a sawbones and taking apart the CT scan and changing the angles within it has probably been the thing that's helped me the most.
Nice. Very
So
true.
I was going to try to go through one case, a little abbreviated, but showing, why I started using IlluminOss. And I think that that's one of the main questions that I get from people when speaking about this or teaching is, what's your indication for this or that? And this was really the case that made me say, I need to reach out and learn about this. And so this was a 63-year-old with renal cell and inpatient consultation, posterior column loss had already been radiated, and large defect adjacent to the joints, isolated the posterior column. These are his legs, and I met him and I said, I hope we're never in the OR together. Let's do some radiation and see how we do. He did well enough, but to get out of the hospital, but not well enough to live. And so I took him back to the OR, and I might have had a trauma partner in the OR pushing me to see how many screws I could put in the posterior column. So I did, and I put in 3, and I wired, I balloon osteoplasty, I cemented, I used a curved nitinol needle to get down the ischial spine. I was quite proud of this and thought that it would do well for him. And this is how I learned in my residency and had kind of practiced early on. And at 2 weeks, the patient walked in with no assist device and celebrating and said, I'm the smartest person in the world. And at 1 month came in and said he hated me. And so you can see, despite ablation and, being careful and having pretty good views, you can see, was it progression of disease? Was it subcontinental collapse? Was it heat generation from cement? We can argue all day about, retrospective guesses, but this hurts, and you can see the screws interdigitating on his head. So, I left the posterior column screws in cement. I modified them though with a burr. So you can see on this posterior column, the cut out and ream just enough, and then burred more. And he did very well for 3 years, and then got back to the construction site and lifted a bag of cement and popped out, hinged off the top. And this just happened last month. And he tried to tell me this was from coughing, and then told me it was from maybe lifting 100-pound bags. So the screws are in the bone, but the cup's not. Right. And so the problem was the whole posterior column was cement and metal. And so I got some super acetabular screws and a nice anterior column screw, but there was just nothing for this cup to interdigitate on, and my screws couldn't go through all that metal. And even if I only had 1 instead of 3, I would argue that it would have blocked me. And I said, I can't have this again. So I just took all this out, and now he'll need some kind of custom for a pretty large defect, and we'll get it done, but it could have been a lot different. And so this was a partner, one of my partner's patients, and I told him I'd like to start doing this. And so this is my first case where I converted to hip arthroplasty. It was not my first IlluminOss case, but my first converting to a hip. And so this man's a 75-year-old engineer from Nigeria, a brilliant man, and had been in remission from myeloma, radiated, and just painful. So not active tumor, but just this radiated shell of bone that remained. And so you can see that it's mostly posterior column and above the acetabulum, but the anterior column remained, maybe the pubic root has some disease, but overall, the anterior column looking pretty good. So I told him I thought I could help him, and because it was my first time doing this, I thought I'd stage it. And so my plan was for a tripod fixation, see how he did. If he didn't like it in a month, I'd offer him a hip. So just showing this void, you can see his sclerotic rim. I did this supine, this was, again, kind of in the beginning of my practice with IlluminOss when I was trying to see what I liked. And I also thought that an antegrade posterior column would be better for him to have the disease controlled more proximally and have more fixation proximally as opposed to distally. So I did supine, and I just went through the iliac crest as opposed to retrograde supine through the ischium. So you can see the inflation and how much there is, and the balloons obviously don't fill the entire defect, but pretty good space. Anterior column fixation, and even though there's no tumor, so it was in the radiated zone, and I wanted some purchase for my screws for the cup, so why not? And why not maximize the support? So I took them in. So these are cannula. If anyone hasn't done this yet, it's kind of fun in the operating room. You see the blue lights and turn the overheads off. So this is the UV light curing process for the nail. I think they were where I planned them to be, and admittedly, he's got joint disease. And so I also, like Dr. Crawford, to learn for myself, and also quality assurance, make sure I get post-op CTs backed off a little bit, but so his joints mostly bolstered more proximally than distally. And this is what it looks like in the OR. So here's a picture on the left of the initial reaming. So the kind of white stripe on the left is the anterior and superior wall, and in the central portion is the clear between the retractors is the IlluminOss. And so I hadn't reamed it yet, but that's what was sticking out. So his head was bolstering on that, whereas the first patient I showed, his head was interdigitating on screws. And so this guy came in and said he was okay, but not great. And the first guy, when his head had cut into the screws, was miserable. And this made me a believer that even if you have someone sick and even if they need a joint and even if you can't do it right then, they're going to be okay because they're resting on something smooth. So I ream, back graft, can't see the balloon anymore. And I put in a cage. This is my first one. I'd say if I were to do this again, I probably wouldn't do a cage. And he's 3 years out now, and I'm to the point like he's teaching me how long do I need to follow these. So I'm learning that now with him. So that was a fun case.
That's great. And I think that's one of the key points of this. This is one of the things that made me use it at the beginning. The first patient that I did, and actually was the first patient that we use Illuminos at MGH, was a patient with melanoma and a BRAF mutation in the and she has disease everywhere. The sacrum, she needed both hips done, lung stems, and the oncologist was like, you have to fix all this before she can start her immunotherapy. So you have like a week and a half or 2 weeks to do case. So it was like surgery Q3 days almost. And I use multi-hole cups. I was very close to use a cage, and but I'm not that good with cages. So I was just like, well, I think a multi-hole revision cup, and I'll just put every single screw that I can. I think it is great in buying you time, and the bite that you get when you put those screws through the cup and the balloon is just one of the few gratifying experiences that you can get in orthopedic oncology. You get like, okay, this is going to work. So great
I like to
points,
have the
Ian.
residents turn the screw as it goes through and watch their face, and it's
Yeah,
very satisfying.
satisfying. Brooke, do you use cages or do you just go with the cups or you use a regular
So
cup
again,
or
it kind of
multi-hole?
becomes fellow dependent. I had a fellow from Montreal with Dr. Turcoy. I don't think I say it
Okay.
right. I'm not very good at my French accent, but it's kind of a cup cage center of the world. And so he wanted to cup cage everything. And I remember having a conversation with him at one point and being like, okay, no more cup cages for the rest of your fellowship. We're done. Like they are just so much more work and much more dissection in these patients who are metastatic. And so I don't think I made a believer out of him, although he did publish about 3 to 5 papers on IlluminOss. So I think I made a believer in terms of the IlluminOss, but I think he would still put the cup cage
You
in.
still put the
I
cage.
think I've
Okay.
put maybe 2 or 3 in total. I think one of them was without any IlluminOss. I agree with you, Dr. Lozano. I mean, I remember putting in some in fellowship with you 10 years ago, and it's just a lot more painful and trying to get that inferior tab to fit somewhere that you like. And I find them a little more onerous, but I do the same as you do. I put in the balloons wherever I think I need them, and then I'll put as many screws and this looks great. I would say too, if you can get the screws, especially the ones up the ilium, even past the balloons and into the bone above, that makes me feel like super good about it. It's like true rebar in those moments. But this looks really good. I'm glad he's doing well.
Thank you. So this is the kind of case where I imagine when someone says, I always use screws. So like you said, Dr. Lozano, I couldn't agree with you anymore. I always do this or always do this. And one of my favorite teachers said, I never always do anything.
Yep.
Um, it's hard to imagine a screw helping this man. So
Okay, do you have another case there,
I
Ian?
do, if we have time.
Yeah,
I thought
sure.
this one was kind of fun. The concept here was connecting the sacrum to the posterior column and to the hip, and then showing some screw interdigitation with the balloons. And then I had planned a staged total hip in order for her to get back to chemo. And again, just kind of reducing infection risk. So 65, endometrial carcinoma, radiation, going through chemo, have been in a wheelchair for about a year. And so this was one of the first cases when the oncologist requested IlluminOss by name and said, can you do this IlluminOss thing for my patient? You know, she's can't walk, and we'd like her performance status look better for as she's recovering. So obviously, intra-articular disease, but then the posterior column and sacral ala also sharing that. So on her CT scan, you can see anterior sacrum, posterior sacrum, S1, 2, posterior column going down to the joint. You know, again, spared anterior column in this situation. And then looking at her 3D, I think this was a little bit more compelling to me because I was debating should I fix the sacrum or not. And um, you know, I thought, what am I going to do all this work on the pelvis, and if we can't transmit the force to the sacrum, you know, to what end have I helped her? So you know, my plan for her was to make like a Lincoln log stack, is how I thought of this, um, about connecting the sacrum to the ilium and doing that by fixing the construct together all as one. I ended up opting out of anterior column fixation for her, which I think is a reasonable discussion point for, you know, if there's not tumor there and it's not that radiated and you don't need it that much for your cup fixation, do you really need to fix it? I opted out of that for her. And then my plan was to take the transsacral transiliac screws into the LC2 or transverse acetabular balloons, and then give her some time to rest and recover, a couple more cycles of chemo, stretch her hip because it had been contracted for a year, do a total hip. So starting with this for the transverse acetabular was where my kind of anchorage point for everything was. So starting again prone with the obturator inlet view, you know, it's when we're doing this, there's always some bone loss, right? So what people ask is, how do you know if it's gone, what to see? And so, you know, looking at this, you have to know your view and how to get there and drive, just getting there automatically. This obturator inlet and find something normal. So the lateral cortex here is normal, even though the medial is gone. And so you just have to visualize what's missing. And so if this view on the right is from another case where the medial cortex is there. And so if you kind of know the width of the posterior ilium when the middle of it's missing, kind of know how much to see over with the fluoro to what looks normal. So, you know, this is a different patient on the right, but I tried to get that view in my head for this person. And then the same thing with the, you know, the lateral view of it for the proximal to distal aiming. And so for this, you know, there's a posterior loss, so find where we have some good bone. And then aiming this on this iliac oblique view, you know, your goal might be different for the, when you're going prone, where your target is at the AIIS. Do you want it buttressing the joint and down to it? Like sometimes I ram it up right to the cartilage, or do you want to fix it up high and be in the AIIS and leave room for reaming? Like maybe if you're putting a screw there, I wouldn't put a screw here, but you can put a photodynamic nail here. So that's why I like that for this. So, you know, here's what I'm trying to see. And again, this is a different case. But if you have this view and get the chance to do it with normal bone, you can treat the abnormal. So I stacked two in the ilium. So I just call this a double stack, and I just put two up on top of each other, and then ran a posterior column through it. Put my sacral screws in again, you know, trying to see your best. And I spun this and navigated this for the sacrum with a cone beam CT. So I just did a spin for my drills. And then here, knowing that you've got the appropriate length, this is your obturator inlet view again, but just moved back. So I like to do the wire through the balloon instead of the drill. Find a little better control that way, and I kind of oscillate it, or maybe high speed sometimes, depending on how it feels. But wire first and then drill through, you know, checking for parallelism in the sacrum. And then I'll skip this just for brevity here. So, you know, the design's there. The hip looks terrible. She felt a little better, but was able to go do some PT, and then brought her back and converted to a hip with a cup that's slightly vertical, admittedly. But she likes it. And even though she likes to stand a little crooked on her standing x-rays, it's there. And she's walking and doing what we wanted to do.
Great case.